it. Next, I would like to call upon Dr. Sima Das, who is the Director of Oculoplasty and Ocular Oncology Services at Dr. Shroff Charity High Hospital, and she would be speaking about implications of genetic diagnosis in retinoblastoma.
Thank you, Shalja. Thanks, Shalja, Professor Natarajan, GGC, for organizing this session and for giving this opportunity to share our experience on working with retinoblastoma. So why we need to know the genetic status of retinoblastoma? Because we know germline versus non-germline RB has a different set of follow-up protocol, different clinical manifestations. We need to screen the siblings, screen the family depending on the germline status. There are systemic implications if the patient has a germline retinoblastoma. And it is also important while if the family is planning any future pregnancies. Little bit about liquid biopsy I'll try to touch upon, and the recent advances in trying to do a phenotype-genotype correlation in retinoblastoma, which until now is not very clear, trying to segregate the tumor into type 1 and type 2. So we all know about RB gene. This is probably the oldest known and the gene based on which all the human diseases has been worked upon. And we all know the heritable and the non-heritable forms, what are the frequency and what are the implications. And clinically it's an autosomal recessive disease, but it tends to get transmitted as an autosomal dominant. Another gene which has now been established with unilateral early onset RB is the MECAN amplification, though we don't see it very often, but mainly because probably we don't test the tumors very often. And we know the implication of prognosticating the effect of on the other sibling future pregnancies based on the laterality as well as the family history if the germline status of the patient is not known. So with this background, let's look at some cases. These are the typical way the RB presents, the unilateral, slightly older onset retinoblastoma, the first child, and a bilateral disease which tends to be early onset, tends to affect both eyes, and we generally tend to see more of unilateral disease, but I think it can vary unless and until we get a large cohort of patients on a wider pool, the referral data can be a little biased. So looking at our own data, these are the 150 data of the initial 150 patients where we have done the germline testing, the consecutive 150 RB patients. About out of the unilateral patient, we have germline positive percentage of about 18%, which is slightly higher than what is reported in the literature. Usually it's 10 to 15% which is reported. Out of this whole cohort, 11 had family history of retinoblastoma, and these are the different type of mutation which has been detected in this cohort. So now, how does it make a difference in an unilateral patient? Like we see this child, very early onset retinoblastoma, unilateral, advanced tumor in one eye, group E at presentation with a neovascular glaucoma. It's an infant, as we can make out, but the other eye is absolutely okay. Now for this eye, we need to enucleate because there was no extraocular extension of the tumor, and we know that this eye is not salvageable. But unless and until we know the germline status of the patient, we can never be sure whether there is a possibility of the child getting tumor in the other eye or not. So we took up the patient under EUA, and we did a genetic testing for this child, and we found a germline mutation. And then we know that this child has a possibility of getting tumor in the other eye. Subsequently, on about 3 to 4 months follow-up, I think there was a small tumor which came up in the other eye. But since we were on close looking for this tumor, we could pick it up at a very early stage, just do a laser therapy, and it could manage the tumor at a very early onset. So unilateral LBU germline mutation, we need to look out for new tumor in the other eye. We need to keep the child frequent follow-up with EUA if the child is very small, and most of them will be small kid. And we need to follow the high-risk follow-up strategy. So there are different follow-up strategy which is given based on the risk, based on the genetic status of the child, whether it's a low-risk group or a high-risk group, and we tend to follow the high-risk follow-up strategy, means a more frequent follow-up for these children. What about bilateral retinoblastoma? So this is a slightly older child. In fact, this child was picked up on routine screening by one of our field workers, leukocoria in one eye, but when we checked the other eye also had a small tumor. So this is a bilateral retinoblastoma. Again, we know this is germline, but there was no family history. We did a genetic testing. He had a mutation in the RB1, and incidentally, he had a new sibling which was just born about 2 months or so, 6 weeks in fact. And this sibling was preterm. So this sibling was in fact taken up for screening for retinopathy of prematurity, ROP, But while the child was being screened for ROP, we could pick up a small tumor in the younger sibling also. Subsequently, this sibling also went on to develop another tumor in the other eye also, so that also became bilateral. But since all these tumors were very small, picked at an early stage, we could save the eye as well as the vision of the second child. For the first child, unfortunately, one eye could not be salvaged, but we could save the other eye. So these are the two siblings. This was before enucleation was done for the first child. So sibling screening is very important, not only for small children, but sometimes you get surprises. Like this family, these are the slightly older sibling. In fact, this kid, the first younger girl, was treated when she was slightly younger. This is his follow-up picture, current picture, but this child was about 2 or 3 years when we treated her. But this child has an elder sibling brother, about 7-year-old. And no symptom, nothing, there are no ocular symptom, vision was okay, everything was fine. But this child, the index case had a bilateral RB, one eye was bad, could not be salvaged. But as part of the routine sibling screening, we looked at the fundus of the elder brother also. Surprisingly, there was another tumor, partially regressed. It could be a retinoma, we don't know, but it looked some area to be active. We started doing laser for this child, and these are the picture after the laser where the calcification has happened. So germline status in a bilateral case, because we know if there is a germline retinoblastoma and if the parents are affected, if it's familial or if the parents are silent carriers, there is a 50% risk of one of the sibling getting affected also. And hence it is important to know also the germline as well as the clinical status of the parents to be able to give a good prognostication. And in our cohort, when you did a sibling screening, out of about 70 odd families, 5 had retinoblastoma in the sibling itself, and 3 of them had affected parents. So again, here we need to follow the high-risk protocol for screening. Trilateral retinoblastoma, we all know apparently intraocular tumor in this child, but when you did an MRI, there was a huge tumor sitting, and this is germline, we all know that. So RB's germline status has systemic implications also, because we know about second primary tumors which are at increased risk, especially if the child is given radiation, and soft tissue sarcomas are known to happen more often in the field of radiation if the child has a germline RB1 status. There are a few unique families. I think I'll skip it. Low penetrance retinoblastoma or the mutation. This part I can skip. And this is one interesting family where the father had bilateral RB treated. One of the child had RB. This was the first child, was why the family came to us. When we did the screening of the children, we picked up bilateral tumor in the younger sibling also. And the mother was pregnant. They were very keen to know whether there is a child of the, because these are all, both are girl child. They were very keen on getting a male child. So we counseled that it's a very high chance because the father is also affected, but still they wanted to go ahead with the pregnancy. We did a CVS. We found the same mutation which the father had and the other affected siblings had, but still they were not ready for the termination of the pregnancy. So eventually the child was delivered. Very small tumor. Immediately after 2 weeks after, I think, the delivery, we did the UA. We picked up the small tumors close to the disc, posterior pole. But since it was again detected early, we could treat it just with focal therapy. So preconception counseling and prenatal testing has a very important role as far as the germline status is concerned. This is the data of our patients. Interestingly, we did 6 out of the 20 families which were counseled. We did CVS for 7 of these families. 3 had advanced pregnancy, so it could not be done. 1 refused. And in 3 fetus which turned out to be positive, MTP was advised and they went ahead with the termination. And all these 3 families where the CVS had showed a mutation in the fetus also had heritable RB, means another affected family member, either the parent or somebody else in the family, also a tumor. So though the literature says it's 50%, I know it's a very small number to say, but at least in this series it looks like almost 100%. If there is a familial RB, the risk of getting another child affected in utero seems to be pretty high. I'll skip this video also. Okay, this was another family where 1 sibling was affected, but just to show that, this child unfortunately had to undergo a bilateral enucleation. We could not save either of the eye. But the younger sibling, we did a CVS. We found no mutation. There was no affected family member. And that child was actually born healthy and doing fine as of now. Little bit about liquid biopsy. What is liquid biopsy? Traditional biopsy, we take out tumor tissue and we check the genetic status in the tumor. But in RB, we know that we can't do that because biopsy is contraindicated in retinoblastoma. So what we do, we try to identify the DNA from the tumor tissue in the fluid, that is the blood or any other fluid, maybe the aqueous humor. Most of the work on retinoblastoma liquid biopsy has been done on the aqueous humor, but in our setup, we realized that, aqueous is not relevant one because most of our patients do not have an anterior chamber when they present to us. Everything is destroyed. So maybe what is more relevant to us is blood-based liquid biopsy, or maybe in those patients who get a CNS mets, maybe a CSF-based liquid biopsy, and that's what we've been working on. And how it can help us, it can also help in identifying the germline status, because if you do not have the tumor, most often the unilateral RB, you tend to do the genetic status of the tumor after enucleation, find out the mutation, go back and check in the blood whether that mutation is there, or if the child is then germline. But since in RB we can't do that, we can do a liquid biopsy, try to identify the mutation in the blood, which is a surrogate marker for the tumor DNA, and then try to go back and see for that in the germline status. The same happened in this child, young child again, presented with an advanced unilateral retinoblastoma, other eye was okay. Germline testing, sequencing, first testing came out to be negative. But we are not very sure. It's a small child. We don't see non-germline RB in such a young age. So we went ahead with a liquid biopsy. There we could identify mutation from the tumor. So we went ahead and did a Sanger sequencing to identify the same mutation in the germline, and the same mutation was now present. Now, so you kept the patient on follow-up. Subsequently, again, the same child developed another tumor, small tumor in the other eye. So that's another utility. Other utility could be, again, this is one area which needs further exploration. In the CNS metastasis, because we know by the time we detect CNS metastasis by conventional cytology, it's too late. We can't treat those children. So if you could treat them or maybe detect them at a little earlier stage before the clinical manifestations have come, or when the bulk of the tumor in the CNS is higher, by doing a liquid biopsy from the CSF, like in this child where there was a recurrent tumor, and at initial presentation, the mutation which we found from the blood as well as from the tumor was matching, and when the child came back with a recurrence, orbital recurrence, still no CNS symptoms, we identify another set of mutation from the blood as well as from the CSF. Unfortunately, eventually down the line he developed symptoms, because right now we don't have any treatment based on liquid biopsy. Our oncologists were not very happy to treat just based on liquid biopsy till we have further data. But somehow this child succumbed to the disease. So maybe liquid biopsy, further work can be done. It can be a tool for early diagnosis and prognostication, especially for the CNS disease settings in our setup. And just a little bit about the two subtypes of the tumor which we are talking about, just to have a phenotype-genotype correlation. This is a very recent paper, 2022, in the Nature Communication. And it's a multicentric study where the group has done a very elegant study of about 100 plus patients, did a multi-omics-based analysis of the tumor as well as other mutational analyses. And what they found is RB actually behaves in two different ways. There are two distinct subtypes of tumor based on the genetic makeup of the tumor. And if we try to extrapolate those subtypes based on the feature they have given, the germline status, age at diagnosis, the laterality, though they have not mentioned about unilateral versus bilateral RB, but it actually hints towards that. So what they have found, the subtype 2, which is basically the unilateral non-germline late onset presentation in our setting, they tend to harbor a more wider alteration, more kind of genetic alteration, including MYC amplification as compared to the subtype 1, which seems to have a better prognosis. So maybe further study in this direction will help us find out why our tumors, especially the unilateral one, tend to behave a little more aggressively and tend to respond poorly to treatment. So I acknowledge the whole team here, oncology as well as the genetics and the basic science lab team here, who has been instrumental in sort of helping us with the RB